So the family is dealing with a lot of information that they didn't have. They're obviously in some emotional turmoil here. They're in shock, as you say. And so what you want to be able to do is to give them some time to come to grips with the information. I think that's a very reasonable intuition that you have, although I'm going to test it. I'm going to attack it because I don't think it's going to be decisive here. There will be certain circumstances under which that makes perfect sense. But we are here to treat the patient, not the family. It's nice to take care of the family, but if the interests of the patient and the interests of the family come into direct conflict, our first loyalty is going to be to our patient. So we really need to know how important it is. For instance, if the family wanted you to do something that amounts to torturing a patient in order to appease them, would you do it?
But she's going to die either way, from the meningitis. Like, it's either a now or later question, correct?
Well, that's true for all of us.
Okay,
So the time she has and what she's going to be subjected to for whatever time she has left is not inconsequential. That matters a lot. Now, if she's truly in a PVS, maybe it matters less because she's not feeling any pain, right? So you could make an argument that for patients in a PVS, let's change the case slightly. We'll come back to this one in a moment. Patient comes in, has diminished capacity, unable to understand the alternatives, risks, and benefits associated with making their own healthcare decisions, so another family member has to make decisions for that person. They're not in a persistent vegetative state, which means they are capable of feeling pain. The family wants to take a course of action which will be very, very painful for the patient and will not increase the likelihood of survival. Will you listen to the family then?
Is the autonomy of the patient not transferred to the family member now?
Well, now that's going to be a question. I saw someone else nod their head. I'm probing on that, and I'm going to show you exactly how to do it in a moment. Yes and no. The autonomy cannot be transferred, although you could have a representative who is going to try to approximate what your autonomous choice would be were you able to have autonomy. So what you're suggesting now would be that we need to take a not the old-fashioned best interest approach to paternalistic decision-making, where one person makes a decision on behalf of someone else for their own good, but what we call a substituted judgment approach, which means that the family should make a decision that the family believes is consistent with the basic or religious values of the patient or any other previously expressed preferences of the patient, which is a quote out of the Healthcare Decisions Act. The surrogate decision maker actually has 3 obligations. The second one is to do a reasonable investigation of the basic values, religious values, or previously expressed preferences of the patient. And then the third one is to actually make decisions that are consistent with the basic values, religious values, or previously expressed preferences of the patient. That's great and wonderful if we had an advance directive and we had any idea as to what the patient would want. But we don't have that, so now we're back to saying, so what are the parameters of family choice? Now you certainly could argue, in the absence of information, we should just listen to the family. But my point is that you don't believe that across the board. Okay? I'll make it as plain as I can make it. I was going to hold this for later, but I'll make it plainer than that now. What's your name?
Callie.
Callie. So now, Callie, you're a surgeon. And I come to you with my daughter, who just turned 13 today. Not really. My kids are older, but imagine. And I say to Callie, Surgeon Callie, thank you for seeing us today. Listen, in the old country, when your oldest daughter turns 13, the tradition is that you hack off her left arm with a machete. Oh, don't worry. I don't keep with the old ways. I'm far, far too educated for that. That's why I'm coming to you, Surgeon Callie, to surgically remove, under anesthesia, in an antiseptic environment, my daughter's left arm. Perfectly healthy left arm. Should you do it? Quick yes or no. This is not a hard question. No. So parents don't get to do whatever they want to their kids. Surrogates don't get to do whatever they want to their kids, which means it's an open question as to whether or not these surrogates get to do what they want to this incapacitated patient. Now, you might be right, but we don't know why yet, and we're going to have to get there. Yeah?
Well, one of the problems that I have with the argument so far is that the assumption is that she can't get better to any kind of semblance of quality of life. And while her condition seems extraordinarily severe, if she's given antiretroviral drugs, her T cell count is likely to improve. Antibiotics would have an effect on her cryptococcal infection, perhaps.
Perhaps.
And so we don't actually have, I mean, I'm reminded of my father who refused to make me his medical power of attorney should he be incapacitated because he said that he thought that I would not, in fact, want to take all extraordinary measures, and he would.
You'd let him go too easy.
And so my mom, however, was far more comfortable with my attitude. So I'm her medical power of attorney. So I guess what I would say is that so thinking against what my dad would say about me, if I was to sort of be a family member and say, but you could give her these drugs, and we could see in in a period of days whether she's going to improve, and if you don't intubate her, we'll never see that.
Your argument has a reasonable place in the discussion, but I think there are two errors that you're making that we need to be careful about. One of them isn't fundamentally an error, but it's an error in this context, which is don't confuse a clinical question with an ethical one. So you cannot reduce this ethical question to a clinical question. If I give you clinical certainty, what would you do with it? In other words, this case came up 15 years ago when guess what? She was a goner. There was no discussion about whether she could get better. But even if we have it now, we can fiddle with the case in order to generate the clinical information that you want to have. Now, it's a perfectly valid question for you to ask. What should we do when we lack good clinical information? But don't confuse a factual question about what medicine can and can't do with an ethical question about whom we should or should not listen to, which is actually the second part of your argument. What you could argue is, and I think this would be a very reasonable argument, in the face of a lack of certainty, although you're never going to have certainty, so it has to be a question of degree. You never, ever, ever, ever wait for 100% certainty before you act. If you did, you couldn't get out of bed anymore. Couldn't stay in bed either. I mean, you might die. The chimney might fall on you if you stay in bed, or you might get in a car accident if you get out of bed, and so you'd be absolutely paralyzed. Okay? So 100% certainty is not a reasonable goal. The question more is, if we're not sure, do we err on one side or the other? Does the family authority trump the physician authority as a function of the certainty of the medical judgment? Now, if you want to argue that, that's fine, but then you will have to be open to the possibility that when doctors do have high degrees of confidence in their diagnoses, that families don't have the right to refuse to accept it. And we know that that's true, because I've had cases where people were pronounced dead by neurological criteria. They're brain dead, but dead's dead. There's only one dead. When you're dead, you're dead. Two ways to diagnose it, biologically, neurologically, but dead is dead. What do we do for a family who says, we don't believe in brain death? So, okay. So now we're almost back to, was it Callie's argument? We're almost back to Callie's argument, which is what we're really worried about here is not the value of the patient or the values of the patient, but rather the family's desire to be the decision maker, which may be true, but it's just going to loop us back to, so then how much do we honor the family that is traumatized? I'll tell you an old joke about that. Two sons live in the same community, and mom happens to live there, and they have families and everything else. One of them decides he's going to go on vacation. So he flies down to an island somewhere, takes off. Calls his brother, who agreed to look after his house and his pets and all that. It's an old joke, you all know this one. And he says, so, bro, how's everything at home? And the brother who stayed back at home says, oh, sorry, your cat's dead. And the first brother says, you can't just spring that on me. I'm traumatized now. I'm on vacation and you just tell me the cat's dead. This is awful. I'm all upset now. You shouldn't have done that to me. So the second brother says, well, what should I have done? So the first brother says, well, the first day I call, you say, the cat's on the roof and I can't get the cat down. And then the second day when I call, you say, well, the fire department tried to get the cat down, but he's still stuck on the roof. And then the third day, you tell me, oh, he fell from the roof and he died. So the second brother says, I didn't realize. Okay, fine. I learned my lesson. So the first brother calms down and says, okay, how's mom? And the second brother says, Mom's on the roof. This is an old joke, right? What's the point? If a patient came into the hospital and was pronounced dead, but you thought it would be terribly traumatizing to the family to find out their loved one was dead, you wouldn't lie to them about that. You'd throw around them whatever supports they need. You call the chaplain, get the social worker, you make sure family's in the room. Is there someone I can call to be with you right now? But you're not going to say, oh, I'm sorry, your child is struggling. Check back in 6 hours. You're going to have to be honest about what's factual and what's not. Your loved one's dead. Deliver it sensitively, but deliver it. For us now to give them room to think that their daughter is going to get better, if in fact your judgment is that she won't, the counter-argument is, are we creating false hope? Now, if the family did what you said, no ethical problem. If they say, I want 3 days to see if there's any neurological improvement, and at that point we can determine whether or not, but what's 3 days? It's arbitrary, right? You have to ask yourself then, are you actually decreasing the family trauma, or are you increasing the family trauma, if family trauma is what you're shooting for? If what you're shooting for is the best interest of the patient, then how does family trauma figure? Yeah.
Could you allow them 30 days to confirm the PBS?
Well, you could, but you're going to be right back to where you begin. So let's assume we give them 30 days, you confirm the PBS, and this is basically your argument. Give them some time to come to grips with it, verify that your medical facts are correct. Fine, we do all of that. 30 days goes by, there's zero neurological improvement. We go back to the family and say, we gave you 30 days, she's not doing any better, it's clear that this is not a good situation. We want to extubate the patient. And they say, no, keep her alive forever. All right, now what? Now you've invested 30 days of increasing the family expectation that turns out not to be true.
So that wouldn't happen though, because at that point then the infections would in fact, both of the infections would in fact, so this patient is not going to be a carrying equivalent, right? So that's the...
Well, you were the one who said we don't really know for sure about anything, so...
It's true, but I mean even 19, if it's 15 years ago, what would that make it? 1990, I'm trying to figure out. It's 1996, there would have been antiretroviral treatments 13 years ago.
We were clearly, at that point, not bringing T-cell count. We did not have anything like the impact on immune systems. And frankly, even today, it's true. You can live with AIDS for a very, very long time. But you've got a train wreck here. This is not a likely success. Yes?
So when do we offer treatment at all? Family has the right to refuse or accept and offer treatment. If there's no treatment that can put on life, why do we even offer it?
Excellent, excellent. One possible approach to this would be to talk about futility. I'm not asking the family to make any decision because I don't think there's anything we can do for her. So I'm not even offering it. They don't like it, they can take her to another doctor and try to find another doctor to treat her. But I don't even have to offer something that I don't think is clinically indicated. Or which is clinically contraindicated, right? It's not just futile, it could be harmful. All right, we got a mess of stuff going on here. And I got to show you that we can do this consult faster than the amount of time we just talked about this mess of stuff. All right? So how would we actually solve this case? And I mean solve this case as clearly as 2 + 2 = 4. Solve this case. Solve this case so that consensus will build around the answer and we can demonstrate that it was the right answer that we came up with. Now, if I could do that, it would be a neat trick. And if we could teach people to do that, we'd have much better health care. So watch. This is how it's done. Or better yet, let me start with how it's not done. Okay? It is not done through theory. All right? Normative ethics is the first place that everybody goes when they have an ethical problem. And although there have been many theories over the course of history, we have boiled the finalists down to 3. And in fact, most people would say, except for Callie, that we've actually boiled it down to 2 because Aristotelian virtue theory is redundant with either deontology or with consequentialism. It's a good argument. I don't believe that's true, so stick with virtue theory. But nevertheless, at best, we have 2 theories. At worst, we have 3 theories. These are the finalists. Now, quickly, because I'm not going to spend a lot of time on this. Utilitarianism is actually a subset of a broader kind of philosophy called consequentialism. A consequentialist believes that the moral value of an action is a function of the consequences of the action. So that, in other words, the good and the right are identical. Bring about a good outcome, you've done the right thing.